Good evening, everyone. Welcome to CAEP National Grand Rounds. Tonight's session is on pain and sedation management in children. I'm very happy to be joining you tonight as your moderator. My name is Maria Ivankovic, and I'm an emergency physician at St. Joseph's Health Centre, Unity Health Toronto. I am thrilled to have three pediatric emergency medicine powerhouses from across Canada with us tonight, who are all renowned researchers in pediatric pain and sedation management. So Dr. Samina Ali is a pediatric emerg doc and a professor of pediatrics and emergency medicine at the University of Alberta. She's an award-winning researcher with a particular interest in pediatric pain management. Dr. Malabat is a pediatric emerg doc and associate professor of pediatrics and the director of emergency research at the Children's Hospital of Eastern Ontario in Ottawa. Her primary research interest is in pediatric procedural sedation. And Dr. Naveen Punai is a pediatric emerg doc at Children's Hospital of Western Ontario and an associate professor at Western University in London. He's a scientist at the Child Health Research Institute with a focus on procedural sedation and acute pain management. So before we begin with this evening's presentation, a couple of housekeeping items. I want to let everyone know CAEP Scientific Planning Committee has reviewed declarations of conflicts of interest, and no conflicts, perceived or real, have been identified, and there has been no external support received for this webinar. So we have two 15-minute presentations tonight. Dr. Samina Ali will speak to us on an evidence-based stepwise approach to analgesia, followed by a 5 to 10-minute Q&A period with all three of our pain experts. Following this, Dr. Malabat will present on the safest and most effective choices for procedural sedation, after which we will have a final Q&A panel session with all three of our experts. We will be using polls everywhere to get some input from all of you tonight. So when the poll is active, go to pollev.com/CAEP18 or text CAEP18 to 37607 to join. So please text us your questions to the number on your screen or use the chat box as your questions come to mind. Thank you to those of you who have sent questions in advance. Samina, thanks for being here with us tonight. Let's hand the screen over to you.
Thank you so much, Maria. I'm really excited to be here. Just going to pull up my slides. Thank you. So thank you everyone for taking time out of your evening to be here to chat with us about responsible pain and sedation management in children, especially in the context of not only a pandemic, but an opioid crisis, which sadly has done the opposite of settle down during this pandemic. It's actually worsened. So before I delve too much further, I'd like to acknowledge that I'm delivering this session from my home, which is located in Treaty 6 territory, the ancestral and traditional territory of the Cree, Dene, Blackfoot, Saulteaux, Nakota Sioux, and the Métis. And I acknowledge the many First Nations, Métis, and Inuit footsteps who have marked these lands for generations, and thank this beautiful country for allowing my parents personally to have immigrated here over 50 years ago, which through opportunity has led me to be here today with you. So as we talk about pain, the first question that comes to my mind, and that of many, I think, is why does this matter? Why does it even matter if we have untreated or undertreated pain? And it matters throughout the lifespan, but especially in childhood. In the short term, it can mean longer healing times, longer hospital stays, more complications, including postoperative complications, and trauma and suffering for the individual child. And then when you get into the long-term consequences, there can be increased sensitivity to pain, increased likelihood of developing transitional and then on to chronic pain, healthcare avoidance, whereas young adults and older adults, these children become individuals who avoid going to healthcare because of their fears. And in infancy and childhood, there's a number of studies now to tell us that it actually affects brain development, EEG patterns, and even loss of IQ points. So lots of reasons for us to take this quite seriously. But what about specifically in the emergency department environment? What happens to our capacity to do our job and to the well-being of our patients when we undertreat pain? Well, it prolongs procedure times, which we know time is space and space is flow. And so slower emergency department flow is also a consequence of poorly treated pain. There's unneeded pain and distress for the child, their caregivers, but not only them, also the healthcare providers. And we all know this. I am certain if you have treated a child in your emergency department and their pain was inadequately managed in the moment, and we've all had that experience, that your heart aches and your team members will come to you and tell you they are dissatisfied and distressed by the experience for that family. It also leads to lower patient and caregiver satisfaction with their overall experience. So let's think about a patient for a second. So this is a poll everywhere. So if you can text your responses to this question. The case is a 10-year-old who falls off her mountain bike while living her best life in the Banff Trails. I am in Alberta, so we need to talk about that. And while wearing her helmet, she has no loss of consciousness, but does have quite a significant isolated distal tib fib fracture with gross deformity of the leg. There's no neurovascular compromise, but when she arrives to your hospital, there's no IV access, and she's telling you she has 8 out of 10 pain. My question to you is, what would be your first line pain management? Intravenous morphine, so establishing an IV and giving IV morphine, intranasal fentanyl, oxycodone plus acetaminophen in the form of a Percocet pill, or oral ibuprofen plus acetaminophen. And I'll just take a moment, because this is our first poll, just to give people a chance to perhaps get signed in and see if their responses show up as yet. And then we can talk about what we see. So I can see a few more answers still rolling in as we're warming up our poll everywhere fingers, but we have about 80% intranasal fentanyl, a little bit of intravenous morphine, maybe around 10%, and then, or 12% perhaps, and then a few people chose oral oxycodone plus acetaminophen or Percocet, and there was one oral ibuprofen plus acetaminophen, but it seems to have disappeared. So maybe they've changed their mind. So about 3/4 to 80% choosing intranasal fentanyl. And yes, I would, for myself as well, if you were curious, that's likely where I would have begun as well. So when we're talking about approaching pain, how do we do this? Do we dive right into the intranasal fentanyl? Do we pull out the dilaudid? Like how do we responsibly use opioids and non-opioids when treating children's pain? And I think the very first thing to remember is that we don't start with the pain medications. It's a multimodal pain management strategy. And I promise you, this is not motherhood and apple pie or fatherhood and apple pie. This is science. So you start with your 3 Ps: physical. So if it's an infant, that can be comfort holds, swaddling, breastfeeding. If it's an older child and it's a fractured limb, like this young lady in our case, then it's a splint. We use psychological distractors. So for instance, this photograph in the middle is actually little Jackson and one of our nurses at the Stollery, Amanda. And this is our IPC approved bubble shooter. So we were able to bring psychological distraction back into our emergency department when our bubble blowing capacity was decimated by needing to wear masks. And then we have pharmacologic options, of course, which we're going to talk about in a bit more detail today. So please don't forget these. They go an incredibly long way for reducing distress and also mitigating our pain processing within our brain to actually affect how we perceive pain. There are 3 basic principles that I'd like you to walk away from this evening. The first is use non-opioid monotherapy first. Then escalate to non-opioid combination therapy. And if that's not enough, add opioid combination therapy. And there, I really do emphasize the word add. It's never instead of, it's always add to the non-opioid. So non-opioid monotherapy, there's a number of really good studies out there. One of my favorites is from like a superstar Canadian. We have so many incredible Canadian emergency medicine researchers in the area of children's pain. It's quite heartening. And this team did the systematic review a few years back and had shown that ibuprofen should be recommended as the first choice for mild to moderate MSK pain as a part of multimodal pain management strategies. And that if you are going, and that you should always combine it with always combine opioid with non-opioid if you are going to have to use opioid later on for greater pain. The recommendations at that time and remain 10 milligrams per kilogram for children up to a max of 600. I know there's some controversy in the adult side between going somewhere between 400 to 800. In pediatric side, we're pretty much, the literature would support 600 as a maxed out dose. We don't have much evidence to go higher than that. I've got that little infants caveat in parentheses because when I was talking about this topic with my pediatric colleagues last month nationally, they raised a very good point, which is that the Canadian monograph for ibuprofen right now for under 4 months of age says 7.5 milligrams per kilogram. So keep that in mind. In fact, it's actually for under 12 months of age. They say 7.5 milligrams per kilogram. So and we had a great discussion around the evidence around that, but it's not great. But just keep in mind that is what the monograph recommends. But 10 per kilo for our children who are likely to be having injuries. If you need more than that and you're escalating, combination therapy is the way to go. And again, another systematic review led by Canadian researchers showed that when you combine therapy, opioid and non-opioid, you reduce the risk of adverse events, which will become relevant in just a second. And it reduces the total amount of opioid needed. But even when you're talking about acetaminophen ibuprofen combinations, that overall, our risks decrease when we combine medications. The dosing, again, 10 milligrams per kilogram for ibuprofen with that infant caveat, and then acetaminophen 15 milligrams per kilogram. And there are a number of studies now for a number of different conditions, including dental conditions, MSK conditions, ENT conditions, that show that this combination is superior to single therapy and also combination therapy with various opioids. But sometimes it's not enough and you need to add opioids. So when you add opioids, don't stop using your ibuprofen. Don't stop using your acetaminophen. Keep at least one of them on board, and then use this as additive or combination therapy. And I've got three possibilities here that I agonized over because there are other options as well, but these are the ones that currently appear to be the most likely to be useful, with the most evidence existing for morphine and then oxycodone followed by hydromorphone. The reason we have options is that there's regional variations, availability, comfort, and indication. So for instance, oral morphine, lots of evidence now to suggest that it does not work for fracture MSK type pain. So not the best choice for that. For, as I was just saying, for oral ibuprofen combined with oral morphine, we have had well over 1,000 patients worth of data from Canadian children across the country now, led by many names you'll recognize, that have now shown us that it's not the way to go for MSK injury. There might be a role in other conditions, abdominal pain or other things, other types of injuries, but as far as MSK injuries go, the answer seems to be a fairly strong no. Keeping in mind, if you were wondering where codeine and hydrocodone were on that list I showed you earlier, they are not there because Health Canada recommends that we do not use them in children under 18 for codeine and under 6 for hydrocodone. And both of them have never been shown to be better than ibuprofen or acetaminophen alone for acute pediatric painful conditions, to my knowledge. So we don't really see a great role for these, and they are more prone to adverse events as well. So what about if they have severe pain to start with? We talked about intranasal fentanyl. If you have vascular access, IV morphine or IV fentanyl are also very reasonable choices. But always remember to include an opioid-sparing non-opioid medication as well. So if I've got an IV, I'll give IV ketorolac 1 dose for its opioid-sparing effects. And if I don't have IV or access, for instance, if I was using intranasal fentanyl, then I would add oral ibuprofen to it. For those of you who like to know what the recommended doses are, I don't want you to worry about copying things down. All of these are in the TREC bottom line recommendation that I'll tell you about in just a moment. So just to sort of round up with a with the last 2 or 3 slides here. When you are prescribing acetaminophen or ibuprofen first, add an oral opioid if necessary, but please don't use codeine or hydrocodone as they are not recommended nationally. If there's significant or severe acute pain, think of intranasal fentanyl, but do not forget your co-therapy. That's my biggest or most common miss is once I go to intranasal or intravenous opioids, I sometimes forget about, or in the past, have forgotten about keeping a non-opioid anti-inflammatory on board. And then when they do go home, if they're still in significant pain or you anticipate significant pain, a modest amount of opioid with a backup plan is essential. So to responsibly prescribe these opioids, we need to remember a couple of things, and I'll go from the bottom to the top. So first, educate your families and patients about what you're giving them and the risks associated with them and the safety of safe ways to use them. Optimize the pain management using non-opioids and multimodal strategies, as we've talked about, and then recognize within yourself and then in conversation with the family that there is some risk associated with short-term opioid use, both in terms of adverse physical events, so respiratory depression, for instance, or somnolence, but also potential for substance misuse later on. So I like to have a script that I share with families. This is the script I use, and in that TREC bottom line recommendation, I'm going to show you in just a second, this script is actually a part of it, so you'll be able to find it there, but it goes over the goals and how to gently screen for substance misuse, which is relevant in pediatrics as well, when we don't have a validated tool to use at this time. This is a handout that we created locally very recently to help families who are being sent home with opioids. And I would be very happy to share this with anyone who would like to have a copy of it. So please feel free to reach out to me if you would like this for use at your own center. And it goes over a lot of the things we just talked about today. And TREC, Translating Emergency Knowledge for Kids, which has an amazing phone app as well that you can use and is free. Has a bottom line recommendation for pain treatment. What you see on the screen is the old one, but it will be updated in the next and published within the next couple of weeks. So there'll be an updated version of this very shortly. So I'll end there to say that all patients and families should have an opioid risk assessment when you are prescribing them. If you're sending them home, usually 10 doses should be enough for most conditions that we treat in emergency. Talk to the families about how to safely use and dispense of the medications. And for the love of all things, if you give them opioids at home, give them a stool softener, or they will stop using the opioids because of the adverse event of severe constipation. So thank you for your time. I'll stop there and be very happy to hear any questions you have at this time.
Thanks so much, Samina. I really like the reminder to treat pain with the 3 Ps. So the physical, psychological, and then the pharmacological. So it sounds like our mainstay really should be ibuprofen or acetaminophen first, and then add the second agent, the ibuprofen or acetaminophen, to that mix, and then add morphine when needed, and 10 doses. Does that sound right?
That's right. Yes, okay. Any one of those 3 oral opioids would be reasonable, morphine being one of them. Yeah, absolutely. Okay.
Now, can our panel join us? We're going to open it up to some questions before we go on to the second talk this evening. So we've got Naveen Punai and Mala Bhatt with us as well. Just waiting for them to come on screen with us. Hi, thanks. Okay, so we've got a bunch of questions. So one of them is, when there is pain and anxiety, would IM ketamine be an option for acute pain?
I can probably field that one. I'm aware of the, it's a great question, by the way. I'm aware of the adult literature regarding intranasal ketamine, particularly subdissociative doses, anywhere from 2 to 4 milligrams per kilogram. Sorry, I'm still thinking about pediatric doses. What we've found is that there's actually not great evidence in kids. There's 2 studies that I'm aware of that have been published in the last 5 years that have looked at intranasal ketamine. They've compared it with intranasal fentanyl, and it wasn't. They both provided pain relief, Neither provided sufficient enough pain relief. So when we say sufficient enough pain relief, to make it easy for everybody, we use a verbal numerical rating scale from 0 to 10. 0 is no pain, 10 is the maximum pain that you as a patient have experienced. And we kind of like to get it down between 3 and less, because that's sort of where the World Health Organization tells us that pain is manageable and less impairing to function. So neither of those therapies were able to actually do that for MSK pain, but intranasal ketamine actually had more symptoms of drowsiness and sleepiness and sedation. So the data is not really strong for intranasal ketamine to reduce pain in children over and above that of intranasal fentanyl. And as Samina correctly pointed out, and I know I always remember this, is that you really need to get your non-opioid therapies on board first, because then it's less likely that you're going to need opioids. So that's my take on intranasal ketamine for pain. For anxiolysis, hasn't really been used as an anxiolytic yet in terms of anxiolytic studies that have actually looked at anxiolytic parameters as outcomes. We haven't seen much in the pediatric literature yet, so hopefully in the future.
Great, thank you. So with respect to morphine, a question around the dosing. So a lot of us don't do as much pediatrics. Sometimes when they work out the per kilo dosing, it ends up being the same as they would give an adult. So are kids more tolerant, or any tips on the dosing?
For oral dosing of morphine, it ranges between 0.2 to 0.5 milligrams per kilogram per dose. And technically, there is no ceiling effect to oral morphine. So in theory, you could keep climbing, but I think all of us get a little bit antsy past about 10 to 15 milligrams. So we'll usually do one dose, max out at about 10 to 15, which would be your oral adult sort of ceiling probably, and then wait and see how they respond to that. But yeah, it is incredible how much quicker children can chew through these medications than adults do sometimes.
Okay, so don't be alarmed if it does seem like an adult dose. Okay, so some questions around ibuprofen now. If you guys can clarify the dosing around ibuprofen in infants one more time. And one of the other questions, I think a lot of us have been taught under 6 months that we shouldn't be using ibuprofen because of increased risk of GI side effects, renal effects, Rey syndrome. So any new evidence to suggest that it is safe in a younger age group? And again, for the monograph that you mentioned earlier, for up to 12 months, are you still using the 10 per kilo?
If no one is feeling brave enough to take that one on, I will do it by default.
Thank you, Samina. Thank you.
It's a tough one because there's a lot of regional variation with this one. As we've discovered, this has been a chat in our pediatric pain interest group for Pediatric Emergency Research Canada just this past week. And the conclusion we've come to is that there is absolutely variation across the country, with some centers being told they are not allowed to use it at under 6 months of age. So in at least one center in Quebec, that is their recommendation. And in contrast, we don't have any such limitations at the Stollery. The typical dosing for ibuprofen is between 5 to 10 milligrams per kilogram. I have always been known to say, and likely quoted as saying, go big or go home. So I use 10 milligrams per kilogram when I'm treating pain for older children, because the vast majority of pain we treat is MSK injury or injury-related pain. And those children are almost always over a year of age, because you don't walk before that unless you're super precocious, and then good luck to your parents. It doesn't become an issue. But when we're treating fever and possible pain in under 12 months of age, I think you have to, as lame as this answer sounds, look into what your local hospital is advising, because there is regional variation. It can be anywhere from 5 to 10 milligrams per kilogram for the dose. And if you are a by the book person, the monograph says 7.5 milligrams per kilogram for under 12 months.
If we were doing from 6 months to 12 months, though, 10 per kilo, we wouldn't be wrong somewhere. Somewhere we'd be right.
That's correct. And it becomes a question of will you have the support of your institution if you choose the higher dose? But I have used 10 per kilo in under 1 year of age and have been very thankful that I have not known of any such complications. But just in recent weeks, this conversation has come to light and is making me wonder if we cannot find more research to support or refute the position that 7.5 is what the makers are recommending.
Okay, that's helpful. One last question about the NSAIDs is you talked about there's good evidence that it works well for fractures. You hear some orthopods saying it can impede bone healing. Is there evidence to support that?
So to my knowledge, there isn't good evidence to support that. They're not incorrect because there was preliminary evidence to suggest that it could. But we don't have current evidence to support that. I can give you some anecdotal stories. I mean, some of our oral morphine work, when we compared oral morphine to acetaminophen, was done in close collaboration with our pediatric orthopedic colleagues here in London. And in discussions with them, they really didn't, and all of those patients had MSK injuries. So one was for post-op ortho pain, and one was for MSK pain in the ED. And orthopedics did not really have an issue with that. I think their rationale is that the risk is tremendously low with single dosing or even dosing for 24 to 48 hours.
Okay.
Absolutely, I'd agree wholly. There's just been another large review of the topic recently published in a trauma orthopedics journal that says, again, no in vivo association with non-union or delayed healing for this. It doesn't appear to be an issue thus far.
Okay, excellent. That's good to know. One question on methoxyfluorine, so Penthrox. So in Canada, apparently it's not indicated in children. A lot of centers are using it with good effect in adults. Is that going to be coming down the pipeline for peds? Any thoughts on that? Don't jump in all at once, everyone.
So Health Canada has approved it about 3 years ago for adult use. So we're starting to see it showing up in our emergency departments here. Within Australasia, it is widely used comfortably and to the point where it's used in the pre-hospital setting as the famous green whistle it's known as, because the device that gives you single use, individual use is a green plastic whistle-like object, and it has shown good effects, but is not widely published in pediatrics. So I suspect as Health Canada moves to approving it for children at some point or prior, we'll end up having to do some trial work with this to see. It's not the solution to everything, because methoxyfluorine also has misuse and addiction potential. So it's not a scot-free drug where we get away with saying we found the perfect solution to opioid. It's kind of like ketamine and fentanyl. It has its own issues.
Mm-hmm. Okay, that's great to know. Yeah, definitely much more popular in certain parts of the world. And I don't know if it's just a matter of time before Canada picks it up. So maybe one more question. Actually, we got a couple more here. Would you use a regional nerve block versus oral versus IV or IN pain control? So would you ever preferentially use a regional nerve block in a child?
I would choose a regional nerve block for the femur fracture that was presented, femoral nerve block. I think I'm comfortable with those just because the visualization is great. So even though we use a fair bit of POCUS at our center, I wouldn't consider myself a POCUS expert, but I'm a POCUS dabbler, I guess. I do use it a fair bit, and I find it's easy to visualize. So whether it's POCUS guided or POCUS assisted, I find it quite helpful. But I also think it's important to give topical analgesia or sub-Q analgesia, and I would choose my patients carefully. If it's an older child who you could explain and you could provide some anticipatory guidance, I would. But for a little one, 3-4-year-old who's broken their femur, I may not choose that route because I think it'll just distress the child more.
I think I could just add to Naveen. I think it's a really important point about choosing your patients, because for another nerve block that we use quite often is the infraorbital. But in order to approach the child with a needle going in their mouth towards their eye, they often need some sort of anxiolysis at the very minimum. So I think that they are great options for pain control, and also not for distorting landmarks on the face. But you may still need some pharmacologic means there if they are young and more anxious. The femur fracture in some cases might be an easier thing because the pain is actually so significant that it's a distracting injury in a sense from the needle pain, but you'd still have to approach them carefully.
And you mentioned you do some topical before you inject. What is your go-to topical? So there's Amatop, Maxilene, Emla. Do you prefer one over the other?
I guess it depends on how quickly you need you would like to do the block, because Emla takes a lot longer than Maxilene and Amatop. Something like a vapocoolant spray might be a better alternative in this situation where there's actually instant, but not as complete anesthesia that's provided. I don't know if Samina and Naveen have anything to add to that.
Yeah, I agree. We use Maxilene quite a bit in our center just because it works faster.
So faster than both Amatop and Emla?
Yeah, we can usually get good superficial analgesia within about 20 minutes. More so is that our nurses tend to like it because it has less risk of discoloring the skin. So, sometimes when you've stocked one item, it's sort of a go-to item that your allied health staff is getting, and it just makes it a little bit easier if everybody is aware of it and uses it.
Okay, and that's your preference for IV starts as well?
That's our preference at our center for IV starts, yeah.
Okay, perfect. That's what we do at our center too, so that's good to know. Okay, we're going to come back to questions after the next presentation. So Mala, if I can hand the screen over to you now, and you're going to be speaking to us on best practices in pediatric procedural sedation.
Okay, thank you. Let me just give this. Okay, perfect. Okay, so thanks very much, everyone. I'm delighted to be here, and I always love to listen to Samina and Naveen. I always learn so much. And so we're going to talk a little bit about sedation. So when we think about sedation, we think that it's safe, that it's routine, and that it's the standard of care. And all of these things are true. But I'd like to tell you a little story about this boy. You may be familiar with his story now because his aunt is a pediatrician, and there's been a significant lobby effort that has followed. But I still think that the story is worth telling. This is Caleb. He was a 6-year-old boy from California. He was healthy, and he was described by his family as being the light of their lives. He underwent an elective procedure at a dental surgeon's office. And present for the procedure was the oral surgeon himself and 2 dental assistants. Caleb was given intravenous midazolam, IV fentanyl, IV propofol, and IV ketamine. Nobody noticed that Caleb had stopped breathing until his saturation monitor alarmed at 60%. The rescue efforts were woefully inadequate. Nobody performed CPR, and no one attempted to insert an oral or nasal airway, and no reversal agents were given. He was without oxygen for at least 20 minutes before paramedics arrived. They achieved ROSC in the ED, but Caleb Sears passed away 2 days later. Now, I'm not telling you the story about Caleb because I think that sedations like this, or even remotely like this, are taking place in your emergency departments. But I'm just telling the story, and I have told this story before, so please forgive me if you've heard it before. It's just to underscore the fact that serious adverse events in procedural sedation outside the operating room are low, but the events with the potential to harm and that require timely rescue are common. There are many known risk factors that predispose patients to these common events, but perhaps one of the biggest determinants is medications. And that's where we're going to focus our time for the next 10 or 15 minutes. We can talk more about the other risk factors in the panel, though, if there's any interest. So as you all know, there are so many different classes of medications, and then many individual choices within each class. On this slide here, you can see the main medications used in procedural sedation and the effects that they can induce. Each medication often has multiple routes of administration. So how do we make these decisions? One way is to consider the type of sedation you're aiming for. I think about it in terms of the type of procedure being performed, which will inform the need for analgesia and the duration of sedation required. The three broad categories are procedures that can be invasive and are moderately to profoundly painful. So procedures that we would do in the emergency department would include cardioversion, a lumbar puncture in a young child, fracture reduction, chest tube placement, and you could probably imagine many more. The second category are mildly to moderately painful procedures. These may be invasive, and they also may be anxiety-provoking. Procedures that I think about in this category are complex lacerations, paraphimosis reductions, wound care, burn debridement, and then perhaps even some fracture and dislocation reductions. And then the final category are procedures that are not painful but require extreme motion control, such as those for diagnostic imaging. And we don't do a lot of this in our EDs anymore, since CTs have become ultra fast, and sedating for MRIs really is not possible and it's challenging for human resources. So we're really just going to focus on the first two categories, but we can talk more about the third later if there's interest. So let's look at a case. This is an 8-year-old girl who was swinging from the monkey bars and she fell. She has a type 2 supracondylar fracture that's going to need a closed reduction in your emergency department. The choices are to give her IV ketamine and propofol, so ketofol, IV propofol plus an opioid, or just propofol alone. Just going to open the poll and I hope it'll work. I'm not actually seeing results. I'm so sorry. We had a little glitch in practice and I'm seeing it now. Anyway, I'd love to hear your thoughts afterwards. So I'm just going to move along here. All right. Okay, so I'm going to talk to you a little bit about a study that we conducted within the PERC network here in Canada that collected data over 5 years. And this cohort is the largest cohort of children undergoing procedural sedation in the emergency department. We looked at risk factors for adverse events, but really the biggest determinant was the medication they received. We enrolled just over 6,000 children undergoing sedation in the 6 emergency departments. And of those 6,000 kids, the overwhelming majority, probably about 60%, received ketamine alone. Other kids received ketamine and fentanyl in combination, propofol alone, propofol and ketamine in combination, and propofol and fentanyl in combination. And what we found in a multivariable analysis that accounted for all known confounders and accounted for small outcomes, we found that when ketamine was administered on its own, patients experienced the fewest serious adverse events. We define serious adverse events as all of the items that you see in the bubble on the screen. And the reason why some of them are grayed out is that we didn't observe any occurrences of these events in our cohort. So there was no complete airway obstructions, no pulmonary aspiration, no permanent neurologic injury, and no death. So compared to ketamine, children who were sedated with propofol had 5 times the odds of experiencing a serious adverse event. Propofol and ketamine had 4 times the odds. Propofol and fentanyl had 2 times the odds. And ketamine and fentanyl had 6 times the odds. Children receiving ketamine also required less PPV than those receiving propofol and ketamine, and propofol and fentanyl. And ketamine's final accolade is that it was also associated with less desaturation than propofol and ketamine and propofol and fentanyl. And I think that these findings are really important because they're, over the last decade, the use of propofol and ketamine has escalated in our departments, but there hasn't actually been any objective finding to the hypothetical benefit of each outweighing the other's down points. But there is one down point to ketamine, and that is that it was associated with more vomiting than any other medication or combination of medications. The good thing, though, is that most of the vomiting that does occur with ketamine occurs during the recovery phase when patients are more awake. And so the risk for pulmonary aspiration is really low. In our cohort, 6 kids actually vomited during their procedure. All of these kids received ketamine, and none of them had a pulmonary aspiration. So it's postulated that this could be because ketamine actually preserves protective airway reflexes. And so that is a thing with ketamine, even though the risk of vomiting is increased. So from our study and a randomized controlled trial by Langston and colleagues from Denver, we know that ondansetron is effective at reducing vomiting, ketamine-associated vomiting. Kids under 5, for some unknown reason, have a very low incidence of vomiting associated with ketamine. In our cohort, only 2.5% of kids vomited who were under 5, whereas the incidence in the older children was 10%. In Langston's RCT, the number needed to treat was 9 to avoid any incidents of vomiting, both in the emergency department or at home. But if you only were concerned about decreasing the episodes of vomiting in the emergency department, the number needed to treat was higher at 13. In our study, we saw a 50% reduction across the age groups when ondansetron was administered. But since the incidence is so low in young children, I really am advocating for its use in older kids. And we give it in the oral dissolving tablet format just prior to sedation. So final word about these medications is to think about whether the child had been given an opioid prior to your sedation. And while we absolutely want to treat pain with the most effective medications, the message here is not to avoid opioids. It's just to think about it and to think about the timing that they were administered, because it will help us anticipate possible adverse events and help us prepare for them. From our same study, these 2 graphs show the occurrence or the probability, they're adjusted probability models for the occurrence of oxygen desaturation and vomiting for kids who received opioids in the blue line and kids who did not receive opioids, which is the red line. Now, the x-axis measures the number of minutes prior to sedation that an opioid was administered. So you can see that the closer that an opioid is administered to the time of sedation, the higher the risk of, or the higher the odds of experiencing an oxygen desaturation or vomiting. There's also a very similar pattern for needing positive pressure ventilation. So this is just something to inform us, not to avoid treating pain, but just to inform us and to prepare us and our sedation team for the possibility that that the patient might need an intervention. Okay, so a second case is a 2.5-year-old boy. He was bit by a dog. He's very anxious, and he has this laceration that's crossing the vermilion border. You don't really feel like you could. Close this without medication, and the non-pharmacologic methods of pain control may not be effective on their own. So the options are intranasal fentanyl and midazolam, nitrous oxide, ion ketamine, and IV ketamine. I'm worried that I'm going to have the same problem, which I am. And so hopefully we'll be able to talk about this in the questions later, but I'll just move along here. So atomized nasal medications absorb directly into the bloodstream. These procedures kind of fall into the second category, where they are anxiety provoking, they may be invasive, and they are mildly to moderately painful. A good choice here is intranasal medications. And as I said, that they're rapidly absorbed into the bloodstream because they avoid first pass metabolism and produce a very good effect. So you can see here, this conical soft plug forms a nice seal with the nair, and the atomizer breaks it up into tiny little micron particles that are very easily absorbed by the nasal mucosa. Fentanyl and midazolam is the most commonly used combination in our emergency department for procedures like this. But despite its widespread use in emergency departments, there are no RCTs, to my knowledge, and maybe somebody would correct me, looking at this combination, and few studies have actually examined the practice. We do know it's safe, though, and there was a recent case series published of over 550 sedations for laceration repair in the emergency department. They showed that the side effect rate was very low. But there was a moderate failed repair rate of 2%. So I'm reading into that, meaning that there was an inadequate sedation. The doses I have listed here are, there's wiggle room in those doses, but these are common starting points: 1.5 mics of fentanyl and 0.2 milligrams per kilogram of midazolam, but that can go up to 0.5. In our department, we only monitor with pulse oximetry, and we don't need the whole cardio resp setup. So it's quite effective and efficient for nursing and medical health staff. You may know that intranasal midazolam actually burns the nasal mucosa when it's administered. So some workarounds have been to administer the fentanyl first because it actually provides pain control, followed by the midazolam, and that works quite well. But if the midazolam is administered by itself, it really does burn and it's uncomfortable. So people give some lidocaine to pre-treat with the lidocaine before the midazolam to provide some relief. But it was unclear whether an additional nasal spray was causing more distress for these kids than just the one spray of the midazolam. So Dan C. and his colleagues from Columbia looked to see whether pre-mixing the lidocaine and midazolam all in the same syringe was as effective as to reduce distress in these kids as giving the midazolam first. Giving the lidocaine first, followed by the midazolam. And what they found was that it was indeterminate. So the co-administration was not inferior to the pre-administered lidocaine. They were similar, but their non-inferior design was not conclusive. They also found that administration of the intranasal lidocaine by itself was associated with quite a lot of pain and distress. So there, it's not clear, but it does help. Another combination for these less invasive procedures was a study done by Julia Hoff and Franz Babel. Franz is from Australia, and Julia, I think, was working with him, but she's from Europe. This was looking at intranasal fentanyl and nitrous oxide for fracture reduction. They included children, 90 patients between 4 and 18 years of age. They included kids with mildly or moderately displaced forearm fractures, wrist and hand fractures as well as dislocations of the finger patella, and kids who needed to be put in traction for femur fractures. They gave 1.5 mics per kilo of fentanyl intranasally and nitrous oxide. The manipulation started 3 minutes after the nitrous was administered, and they looked to see whether there was a difference in the FACES scale before and during the procedure. And they found that it was effective, but there was quite a lot of nausea in about 20% and vertigo in about 23%. So, yeah, so that's that. Some other medications, we talked a little bit about the IN ketamine earlier in the Q&A. There was one study that looked at intranasal ketamine for laceration repair, but the doses needed, they needed up to 9 milligrams per kilogram to get adequate sedation and motion control for laceration repair. And these doses are really quite high if you don't have the ultra concentrated ketamine that we usually stock 50 milligrams per mil, but you really need the 100 or 200 milligrams per mil to be able to provide this effectively. Dexmedetomidine is also given intranasally. This provides really good motion control, but really not great pain control. The downside to Dex is that it does have a longer time to onset, 15 to 20 minutes time to onset, and has variable length of sedation. But Naveen is performing some really exciting research, and he's looking at the combination of intranasal ketamine and dexmedetomidine in the emergency department for mildly angulated fractures of the forearm, and that study's underway. So this is really exciting, and I'm sure he'd be happy to talk more about this in the panel. So I'd like to just draw your attention to the TREC bottom line, as Samina also drew your attention to the pain bottom line. A lot of the information that we talked about today is included in this, and I'd encourage you to have a look. It provides some dosing as well as some pediatric specific considerations. So just to finish things off, I think that I want to make sure that we know that procedural sedation is absolutely safe. There are very few serious adverse events. And I think it's because we choose our patients carefully and we are skilled as emergency physicians in performing rescue if there ever needs to be an intervention. Choose your medications according to the procedure performed and by the safety profile that you know about. It's good to have lots of tools in the toolbox. So it's good to have ketamine and propofol, ketamine alone. By saying that ketamine alone is the safest, it certainly was associated with the fewest serious adverse events. But if you are very comfortable with IV ketamine and propofol in combination, this is something that is probably more valuable than moving to a medication that you're not comfortable with. And then finally, just to consider the IN route as a good alternative to the intravenous route for some indications, some procedures. And thank you.
All right, thanks so much, Mala. I think this really helps streamline our evidence-based choices for sedation. We're going to go back to our expert panel to use our last few minutes to answer some of the questions. We actually had a lot of questions in the chat box. So I'm wondering, Gail, if we could put an email up there where if we don't get to all these questions tonight, where our viewers can reach out to get the answers. So maybe we'll start. There's a question around emergency reaction. Is there any evidence to support pre-medication for emergence, or what's your approach to that?
So there isn't actually. You know, we emergence is something that we tend to treat now if it comes about, because we used to treat with midazolam and ketamine, if you remember, and it really was shown to be associated with more respiratory depression and more vomiting, actually. So we don't pre-treat, and the number of significant emergence reactions is actually quite low.
Okay, great. Now, what about the dose of ketamine? Do you at higher doses get more vomiting?
So that's interesting. You know, our study was the first to show that there was a dose effect. Ketamine is known as a threshold drug. Like once you've saturated your NMDA receptors, there should be no added effect. But we found that for every milligram per kilogram extra of ketamine that was given, the rate of vomiting increased and the rate of oxygen desaturation increased by about 30%.
Okay, that's helpful to know. How long does the IN fentanyl and midazolam mix last? Like how long do you get a good effect?
Well, I actually don't know the timing, but it's always been, I mean, I don't know, Samina and Naveen, maybe you know more timing, but I would say 20, 30 minutes.
Okay. Any tips on using the atomizer? Like, do we have to count for that dead space? What if the kid is very, very snotty? Any advice?
I can't really answer the dead space. I feel like Samina and Naveen might be better equipped for that. But the snotty question is a really good one. If there's a lot of congestion in the nasal mucosa, the drug will not be very well absorbed. And so that should be, I guess that should be a consideration when you decide on your route.
Yeah, I agree. So the Ketodex trial is helping us to sort some of this stuff out, but we're also doing a pilot study, not really a pilot study, a dose finding study of intranasal dexmedetomidine for laceration repair. And that's what we're finding. So we've tried to optimize our protocol. We actually work with Dan C's group at Columbia. And right now, like I know Mala had shown that photo of the kid lying supine and getting the spray. So what we do is we position them at 45 degrees. And then we aim for the back of the head, so not straight up. And we use we talk to our manufacturers who make the device, and they say that the dead space volume is 0.15 mLs. So nurses actually, when they're drawing it up, if you just tell them that number, and if there's any nurses on the call, they can attest to this. They kind of do this without thinking, so they'll automatically push the drug forward until they get a bleb at the end of the atomizer. And then we also try to divide the doses into each nair, and we don't give more than 0.5 mLs in each nair with the patient in a supine position at 45 degrees. One thing I would caution you though is that when your child is starting to fall asleep, some of the little ones will slouch down in their bed and they'll obstruct. It's pretty easily reversible. You just put them flat. But we've started to as soon as we watch them when they're starting to fall asleep, we kind of put them a little bit more recumbent to avoid that.
Okay, great. Very good tips. So we're actually out of time. I think we have to invite you guys back. You're so popular. There's so many questions. So hopefully we can forward those to you by email. We are truly lucky to have such experts with us tonight. I definitely picked up a lot of pearls, even after doing this job for so long. So thank you so much, Samina, Mala, and Naveen for being with us this evening. And thank you to all our attendees. Please remember to complete the evaluation. Your feedback is very helpful for future CAEP Grand Rounds. And please mark your calendars for our next CAEP National Grand Rounds, which is on Wednesday, May 12th, on trauma-informed care. featuring an incredible group of speakers. So that's all for tonight, and I look forward to seeing you guys again soon. Thanks so much. Good night, everyone.